So welcome. My name is Benjamin Shickel. For those of you who don't know me, I am in this division. I'm one of the AI faculty, assistant professor in the Department of Medicine or division, also the associate director of education of IC3. And today I'm talking about AI. Surprise, surprise, but this is specifically AI-enabled clinical decision support for acute care, and more broadly, sort of recent developments in AI, with a kind of a focus on some of the systems that will probably be, you'll be seeing them quite soon, if not already, within your hospital system. No disclosures here. I'm gonna move this for a second. Okay. So as we all know, as we all have heard, AI is rapidly evolving, has the potential to significantly impact nephrology, broader clinical care. Whether that impact is positive or negative, I think is up to us. And so, one of my goals today is to sort of provide this background, base level of knowledge, understanding about what AI is, what AI can do, what AI can't do, so that, you all can become AI-enabled clinicians, or, clinicians who are familiar with AI, know how to use it, know when not to use it, what contexts might make sense to use it, which tool to choose, how to interpret the results, when to reject the results, when to spot an obvious error, things like that. I think are all really, really important questions that a true AI-enabled clinician will be able to answer. And then ultimately, we want the clinician really to become a human in the loop, so sort of a clinician in the loop, where you all are not using the tools, but you become a part of the tool, and the tool doesn't even function without input from you all. I think that's the true sort of symbiosis and the end goal. And of course, understanding the risks, the benefits, and the limitations of AI. AI is not magic. It's statistics, it's math, it's data, it's coding. And so there are several limitations, obviously, there. The overall objective for today is to discuss the recent developments in the context of applying AI in critical care. So,
Ben,
yes.
silly question.
Sure.
When you say AI/ML, can you just tell me what you mean?
Sure, and I have a slide that differentiates those. I hate that term actually, but the NIH uses it all the time.
The slash one or the machine learning?
The slash one, yeah, AI/ML. Broadly speaking, AI is this sort of umbrella term that refers to any machine or system that mimics human intelligence, that can perform actions that normally require human intelligence. So it's very kind of general definition.
I want one spicy
chicken and the algorithms to
chicken
learn
sandwich.
From data. Okay, thank you.
Meal.
But I do have
medium.
I'll be up sometimes soon.
And
So
it
these are
contains
the
on
broad
which fries,
topics
right?
I'm going to be getting into today. So
With
first,
chicken,
where are we now?
fries, right?
What does clinical AI look like? And actually,
Okay.
I'd be really interested in talking with
Can you
someone to
also
see
give the chicken
in
nugget,
AI
maybe
in
4
your practice
pieces?
yet, because I know it's coming or it's
Spicy.
here. Is it every day? Really?
Maybe
Okay, great.
barbecue.
No. Yeah. That's good to hear. I think more functionality is coming soon, from what I've heard. So there's lots of new exciting things, exciting to me. I don't know how you all feel. I'd be curious to hear your opinion as well. But so where are we now? What is AI? So I do a bit of a primer on AI, just a few slides of sort of what AI is, because I find that it's difficult to kind of meet in the middle, talking with clinicians who don't even understand what AI is. They hear about it all the time, obviously, but what is it, So I do a little bit of that. Then we're going to focus quite a bit on the large language models in healthcare that are probably driving some of the tools that you're using every day. And then after that, sort of the potential for non-LLM, so non-language model based AI. There are different types of AI, and we'll get into that as well. But sort of the potential for continuous monitoring, I think, in nephrology and acute care, critical care, specifically, where the data is very, prevalent. We have lots of data, high frequency data. I think AI can thrive in an environment like that. And these are things that are sort of on the horizon. They're not there yet, I think, because the stakes are higher, right, than summarizing a document or writing a patient note or something like that, which is why you're seeing those applications first. I'll end with a few slides on digital twins, other sort of work that we're involved with that's not exactly related here, but represents kind of another use case of AI for acute here. All right, so where are we now? So I'm starting off here with this survey from the AMA, 2020 3, I believe, published 2024. The first result here is about the current AI usage among physicians, where it said that 62% of them have never used AI. They don't use AI in their practice. Now, this could be, I'm not sure exactly when the survey was conducted in 2023, so this could be updated by now. Could be different numbers here. But I thought that was interesting that 62% hadn't used it, and maybe not sure if that's due to not being available or decided not to use it or what have you. The second result here is whether you are excited or concerned about AI. And I think we see like a nice balance there of, so the first one is more concerned than excited, and you have more excited than concerned, and then equally concerned and excited. There's lots of concern, lots of excitement. No one knows what to think, I guess. But that's good to see that there's excitement at least. And then finally, we have the clinical AI opportunities, where you see the first bar there. The majority it's probably hard to read here, but it's addressing administrative burdens through automation. I think some of that note taking and things like that, and summarization, things like that fall into that category. But I'm also pretty interested in this next one, which is augmenting physician capacity. I'm not sure exactly what that means, but that sounds a little more in line with some of the critical care, continuous monitoring stuff that I talk about later in the presentation. Okay, so we have, whoops. When I gave my talk last year, I forgot what the number was, but it was much lower than it is now in terms of the total AI authorizations by the FDA. So we're up to over 1,000. We crossed the 1,000 mark. You can see here that's an exponential curve. So it's rapidly accelerating in terms of real world AI. This isn't just research that you write a paper and you throw it away or whatever, but this is actually happening. This is becoming real. You can see by specialty, vast majority is still radiology, and cardiology is next, and you kind of go down from there. So this slide is about a sort of a cautionary slide about the FDA. This was a nice study done last year, published in Nature Medicine, that looked at these FDA authorizations, and I think at that point it was probably around, I'm not sure what the total was, but around 150 a year or so. They looked at all of those, sort of the summary statements or whatever they call them, that's published on their website with the authorization. And they found that most of them lacked sort of adequate validation data, and found that most of them were not actually validated at all in a clinical setting with real patient data, which I think presents a very, very important problem, and everybody should be alarmed at that. Furthermore, a lot of them used simulated data to train the models, which I think is crazy that things like that are being used in practice. Just knowing that how different simulated data can be from real patient data. I mean, there's a myriad of issues that come along with real patient data that aren't adequately modeled and addressed when you're training on synthetic data. But in any event, this is sort of just a cautionary note here, and I hope that we can work on getting more validation data. I'm not sure if it's because they weren't validated, if it's not published. The article didn't really specify that. But you see that since 2016, that the authorizations without published clinical validation data outnumber the other types of studies. So I think that's pretty concerning. Yeah.
What is being FDA approved mean, and what is required? What does the FDA require in order for this to be FDA approved? Because I've seen unpublished proprietary data.
Yeah, that must be why it's not published. They probably claim it's proprietary or trade secret, or so I'm not a lawyer. I'm not exactly sure what goes into FDA authorization. I'm not sure what's required. I'm not sure what's typically required for any other medical device. I'm not sure how AI is different. So these are things that are interesting.
Can I ask a question on this?
Sure, yeah.
Of course, when we see that there's no clinical validation data and data is based on perspective, but it does have to put it in context about how that thing is being used. Let's say if we have an AI working like a physician, like let's say you're looking for breast tumor and there's no verification of what AI does, then of course we need a strong clinical data. But if AI is all it's doing is flagging it for the pathologist to review it or radiologist to review it, then do they need validation data from clinical aspect? Because it's just an assistant.
That's true. That's true. To me, maybe as a lay person, I guess, when I hear FDA approved or FDA authorized, that's kind of like takes it to the next level for me, right? I don't know if that affects things, but you're absolutely right. There are levels in their categorization at level 1, 2, 3 based on the stakes, basically the level of automation, whether a human is required or not.
Right.
And so I assume that the bar is higher for the fully automated systems. Absolutely. I'm not sure. This is sort of just like let's slow down, take a breath. The pace seems to be accelerating quite rapidly. I trust them. I assume they know what they're doing, but this is interesting to me as a non-clinician. I'm not sure how you guys see FDA approval, whether it factors into decision making on using a certain device or method or what have you. But just sort of interesting to me here. Okay, so this slide is about something else that's concerning to me, and that's who's developing the AI that's being used. You use this every day in clinic, but it's being developed actually by who knows who. Basically, it's being developed by industry, right? OpenAI, Google, Meta, Anthropic, other companies, Microsoft, Apple, NVIDIA. Industry is developing the AI that is rapidly being disseminated into healthcare systems across the country without the input of doctors, which I think is quite scary. But this slide here sort of it shows some figures. This was actually before the Chat GPT explosion, basically in 2023. So I think these numbers stop in 2020. So I can only assume it's even higher now. But we have much higher percentage of AI PhDs going into industry than research. The number of machine learning models, of significant machine learning models, is being dominated by industry. This is in publications, and furthermore, industry has sort of pulled back on their publishing. They used to be sort of big players in the research space as well, but now that billions or more dollars are on the line, they've sort of stopped publishing how their models work and things like that, which presents another set of problems. But I think this should be a warning to everybody. To kind of consider where the models are being trained, the influence that these private companies have on the models that could eventually impact real patients is a little concerning. I don't know what happened here, so I'm not going to spend too much time on this one. This came out a few days ago, actually, and I thought it was quite interesting. They proposed a framework for building trustworthy AI. The squares are in the right places. The one on the right was talking about the opportunity for clinicians to work with the developers to build the systems, which currently is not being done, which I think is a big miss. We're just using what they develop. And so the next slide here is just sort of plugging some of our work that we're doing that involves co-designing AI with physicians. We do a lot of work. I do a lot of work with Dr. Yorick on some of her models and her systems for surgical predictions. We're doing things with quantifying the uncertainty, making models more explainable, propose this set of standards that represent, the comprised ideal algorithms in healthcare, so fair, reproducible, things like that. But the point is that we're working with clinicians to design some of these things, especially the clinician explainability. We're doing focus groups and user-friendly interfaces, seeing what they want to see, what works for them, and things like that. So I won't spend too much time there. Okay, so now we're at the what is AI part of the talk. And that's where we see this sort of taxonomy of terms here. We start with AI, which is things similar to what I said before, but it's about the science, engineering, and making machines that can perform tasks that would normally require human intelligence. And machine learning is the subfield of AI that uses data, learns from data to do certain things with algorithms, essentially. And then furthermore, we have deep learning, which is a subfield of machine learning. And that's the one that is associated with artificial neural network models. These are the ones that are dominating the most recent developments. Large language models are a form of deep learning. Facial recognition systems on your phone or anywhere else. I mean, that's deep learning. And pretty much everything that you use these days is deep learning. And deep learning is notoriously a class of models that are black boxes, essentially. So they're not very interpretable or explainable. You don't know how they're working. They work well, but you don't know how they're working. And I get into that distinction in a couple slides later. So we have a nice figure here. The AMA has sort of co-opted the AI term. They call it augmented intelligence. I guess to sort of ease concerns that you guys are going to be replaced as physicians. So they want to emphasize the fact that it's going to support you and augment you and not replace you. But it means the same thing. I won't spend too much time here. This is deep learning. It's the models themselves are artificial neural networks. There are many types of them, many families. Sort of things kicked off in 2012 with deep learning in this competition, this ImageNet competition. And since then, it's been on the rise ever since. So a final term for our dictionary, our vocabulary that I want to throw out is data science. And you might have heard of this. It's the science of extracting knowledge and insights from data. It's closely aligned with machine learning and artificial intelligence, but I think the main distinction here is that you're gaining insight. So it's the process of extracting information from what you're doing. And so I like this quote, Andrew, he says that the output of machine learning is a piece of software and the output of data science is a slide deck. So you're sort of presenting work. I think a lot of what we do in research here is data science and not so much machine learning. So I thought it was pretty interesting. This is also sort of entertaining, I guess, sort of what goes into data science. There's this danger zone where someone knows enough to be dangerous, basically, with hacking, with coding. They have the domain expertise, and they just go wild, coding things up, and you have the risk of improper analyses, unsupported conclusions, and things like that. So all of these are important for data science.
Just a quick question, point of clarification.
Yeah.
When it comes to deep learning,
Mhm.
we still, you in your field, what I understand is you don't really know how that happens still, but you can model it.
We know how it happens. You can think of these very densely interconnected neurons, they're called. And data goes in, it passes through all these layers of neurons, and what comes out as a prediction, is the patient going to die or not? And it could be super accurate. But if you want to know why it's making a prediction, like which inputs are most relevant for the prediction, it's difficult.
That's difficult.
Yeah, that's the difficult part, right? And so I think it's a matter of weighing. It's a very context-based decision. What the stakes are? Do you need to? Do you care? If you want to know, if you have a model that predicts tomorrow's stock price with 99% accuracy, do you care how it's making the decision?
Yeah, that's
I would.
okay.
But anyway, that's a whole area of research called XAI, explainable AI. That's developing methods to explain some of these black box.
I heard that in some of those cases where they actually did go and find the algorithm that the computer generated to, for example, I heard that they used the AI or the deep learning to diagnose skin cancers. And when they looked at the algorithm the computer had generated to do that, they look at the computer take things like in the presence of a ruler, measuring tape.
Oh yeah.
Well,
Yeah.
So when you look at it, you can find that it's doing things which are not what you want,
Yeah, back in school I did a project that picked up on like the stain color of a slide or
Right.
something like that. And it was like, it's not relevant information. So
Right.
that's something you
It's
really
accurate,
take care
so
of.
it's right, because people, when they find cancers, they usually measure them, but that's not what you want it to be doing, right?
That's not, no, because it's
Right, yeah.
So I have a slide on this.
Okay.
One thing, so
Yeah.
do you mind if we spend a little bit
For
time
sure,
on
yeah,
this one,
absolutely.
because this is where you guys eventually take over. So. No, I mean, I meant it with utmost respect. I think just a concern, so if I'm understanding correctly, in order for your various model below to work, you have a variety of conditional formatting in terms of linear or logistic regressions, which then you interconnect into a sort of a deep neural network. And that eventually that particular format is implemented for each of the variable that you identify or are present in the data set.
Whatever you want. For computer vision, when you're looking at an MRI or an X-ray, each of the inputs is just a pixel intensity or something like that. It could be the data that I work with most is EHR data, so it could be vital signs, medications, lab results. So you sort of structure that in the beginning, but then you just sort of pass it in and let it figure out the relationships between different data types, right?
But in order for that
Yeah.
relation, the
Yeah.
first relation to be established, do you require it to have a clinical or probabilistic relationship pre-existent, or?
No,
you
no, no, no,
just-
no, that's sort of an art. Can be more of an art than a science sometimes, where I don't know if it's an art even. You throw everything into a box and see what comes out.
And then you model it after it comes out. Then you do the math.
No,
There is no
there's actually
math.
not a lot of math
Yeah.
involved with some of these things. These are meant to be tools a lot of the time, where you're using a tool instead of gaining insight. Actually, I've slide on this too.
Okay.
Okay,
But yeah, you're right. I mean, and this is also, it's a simplification, it's oversimplification. The sort of the architecture of deep learning looks like that, where each neuron is sort of doing something similar to this logistic regression, but the way that the weights are updated is a little different than what you would do for regression.
my apologies.
Yeah.
So, but at the most basic level, these are the atoms of those relations, correct?
For the fundamental type of deep learning, for the fundamental artificial neural network, yes, yeah,
Got you.
yeah.
So the variable, or sort of what we call in statistics as independent variables, are just a bunch of things that we have
It's whatever you have.
that you just throw it in. And the program itself, the deep learning part of it, is that it is examining the relationship between, for the most simple relation, independent and dependent variable. And then it is examining various collinearity and sort of addressing each one, either
Maybe.
collinearity or, oh, we don't know that.
No,
I
that's the
see.
part that's why it's a black box, because you know what's going in, you know what's coming out, you don't know what's going on in there really.
But who
That's
decides that?
maybe not doing justice to my colleagues who work on research, but that is sort of an active field of research. You know, it's not done. You know, it's not a solved problem. You're hoping that the model learns to minimize features that don't matter and inputs that don't matter, covariates, whatever you want to call it, and emphasize the ones that do matter. At the end of the day, it would be accurate, like it leads to an accurate prediction. And I have a slide on the predictive part of AI. It's different from the classic statistics that's more concerned with like extracting information from the model about the real world.
Who gets to decide that what happens to those things? Like, what's that? Is it a commercially available like who makes this LXNet lens, like whatever it is?
Yeah, we do. That's us.
I see.
Yeah.
But you don't know. Okay.
The thing is, a lot of what we do is it doesn't make it to it doesn't get deployed, right? It doesn't make it to clinic, right? And that's what we're hoping that it will. But a lot of the research that we do is developing a new model with higher accurate, like performance, predictive ability. So we're concerned with metrics like that. Maybe I'm missing the point. I'm sorry.
No. I think what I'm trying to say is that, like, what I'm trying to understand is that we understand that part. We understand that you are assigning a relationship of a probabilistic and output cell and match input and out. Those things we understand. What we have problem in clinical world is who gets to decide these relation and their weighted, and what program decides that. And that part always is confusing. So who is that person and how do they decide where this, like, what's the governing principle of that box?
If I'm understanding you correctly, yeah, no person decides that. Like that's the beauty. I don't know, that's how deep learning works. It optimizes an objective function that you have control over what you're trying to optimize. And typically it's accuracy or AUC or sensitivity of a certain sort of diagnostic or something. You define what you're trying to optimize. And the model, it's called gradient descent. You know, I don't want to get into the weeds too much, but it learns from data to optimize that algorithm. And it could go the wrong way and pick up on a ruler and an image, or it could pick up on things that you already know. I think a lot of us are hoping that it can pick up on things that we don't know that actually are meaningful, and then eventually sort of unwind that ball of yarn to see like what's driving the prediction. You know,
I think what
explain
I
it
was saying
super
is
important. Yes.
So, but a human is writing the code
Yes.
that then the computer unleashes to do all this.
Yes, exactly. So we're defining the parameters of this
How it does.
thing and then letting the machine optimize it iteratively. sort of taking steps towards this optimal solution that you get to define. If you're trying to optimize like sensitivity, it'll take different steps
So
to get there.
would it be reasonable to say your simplistic code would look like that run this analysis, run series of these analyses, pick the most likely one, discard these ones, go to the next one? Would that how your codes will go? Will it, like, how would that, is that, where do you start putting the weight on these individual atoms?
That is what the code looks like, but within each cycle of that code, it's not, it's, trying some different, so each of these models has different little knobs that you can tweak, like parameters of the model, you can kind of tune. And so we have like loops that go through and try different combinations of those to see what results in the best performance, but each experiment is not, it's dictated by the model, the learning process, the optimization process.
So you write those, then you write this, and then machine does a bunch of things in an iterative manner.
Basically, yeah, and we could talk later about that too. Yeah,
Fair.
yeah. No, it's super interesting because I'm not sure where everyone's at in terms of like the AI understanding and machine learning and stuff like that. So super important. Okay, I'll move on. Yeah, so this one is about the difference between sort of conventional statistical methods and what you might call machine learning. And I found this myself multiple times with potential collaborators here at UF. MD researchers who are used to, they're quite familiar with the statistical modeling part, or sorry, with the conventional stats part, but not so much with this algorithmic modeling culture. So this paper came out a long time ago, actually, 2001, and sort of divided the statisticians into these two camps, basically. One is the data modeling culture, one is the algorithm modeling culture, and they're both sort of approaching this. So any statistical problem looks sort of like this up top, where inputs go in, you have a response, something happens to transform the inputs to a response. The goal of the data modeling culture, which is the conventional stats sort of people, probably what you all are most familiar with, is to extract information about nature, right? If that makes sense. And for us, maybe more so, AI people are sort of leaning more towards this algorithm modeling, where the goal is not, I think ultimately it's about extracting information, but the immediate goal is prediction. So a model that can generalize moving forward. So like a risk prediction tool or something like that. So it's a little different in terms of goals. I think the paper goes into, and an author developed the random forest algorithm. So I think he's in this algorithm modeling camp. But I think both types of stats can get at both of those goals, but the data modeling favors the information extraction, and this one favors the prediction part. And I think which sort of approach you take is always contextual, but it depends on what you're trying to do. I'm just going to skip this one. It's a nice paper. Encourage you to read it. To the New England Journal a couple of years ago, kind of compared all of this, and I think it's quite useful for the types of work that a lot of us are doing here at UF. I know I said that I have a slide on it to some question, and this is one of them. It's about sort of AI. One of the goals is to predict, right? And you're trying to generalize moving forward. Something else that I saw working with people here who weren't quite familiar with machine learning was that you fit a regression model and then you call it a day. You look at the coefficients, right, to see what factors are important. And I asked how good was the model? How accurate was it at predicting? And they didn't know what I meant. I wasn't sure what they meant. It was it's kind of awkward at first. Just kidding. But yeah, so it was different for me because I'm from this algorithm camp, I guess, this culture, where the goal was always to make predictions with your model. So you want to see how accurate the model is. It seemed like you fit a model to data, and then you immediately start analyzing the coefficients. So what if the model is a bad model? I've seen plenty of bad models in my day. I've trained them myself that can't predict better than a coin flip, right? At some outcome. I wouldn't read anything into those models, So just my whole point with these slides is just, it's something that's interesting that we all should consider. We're coming from different places. This slide in particular talks about underfitting, overfitting, which is an issue of machine learning, where if you have this data set, patient data set, for example, you train a model and it performs super well, predicts very well on that data set, then you try it again, maybe prospectively in a month or two, and it performs terribly, well, your model probably overfit to the training data. So the goal is to generalize to future data, geographic generalization, different institutions, maybe different patient populations, different equipment practices, many things could be different in healthcare data. And the goal is always to generalize. So there are methods to account for that. And I won't spend too much time here though. I know that probably a lot of you want to comment on that as well, but I'm happy to talk about it after. Those are really interesting topics to me. Okay, this one is generative AI. I think we're probably all familiar with that. ChatGPT is a form of this. I've probably seen clips of crazy looking, realistic images and now videos. That's all generative AI. And I have this slide here just to differentiate it from predictive or discriminative AI. I think the field is still trying to find the right term for that. But classic sort of machine learning up until years ago was always sort of predictive AI. So if the patient has a 75% chance of having AKI in the next 48 hours or dying in a hospital before discharge, something like that, predicts an outcome with some confidence or some probability. And generative AI is a little different. It's about generating new data. So the way you evaluate those is typically these human studies, having experts rate how well the model generated whatever it's trying to generate, something like that. It's sort of a different, sort of newer type of AI. And I think I have one of the variants, so don't worry. Okay, so moving into LLMs, which ChatGPT is one of them. These are sort of technology that's driving a lot of the tools that are making their way into EHR systems and being used by everyone basically. And I think it's just super important to talk a little bit about these because I'm one of the co-faculty instructors of the AI and medicine pathways for medical students, the research and discovery program there. And they're all using ChatGPT. And I just enjoy talking to medical students. It sort of is concerning to me, but they're all using it to study. They're learning from it. They're using it for various things. They're creating study materials and things like that, which is great if it's accurate. I'm a little concerned, but it's everywhere basically. And it's hard to regulate too, because everyone's got it in their pocket, right? How do you even in the hospital, if you say you can't use it, well, anyone can pull it out and use it for something. So these are here to stay. I think no one really knows what the landscape will look like in 5 years. But the pace of advancement here is just astounding. But it starts at natural language processing, which a lot of you guys might be familiar with. This is sort of the slower paced, not a groundbreaking study every month. This was been going on for a couple of decades, few decades maybe. Classic things like extracting terms from clinical notes if you want to make structured. You want to take your unstructured notes and extract some structured entities from it. Things like that, in terms of the clinical use cases. Lots of different natural language processing tasks there. But this is sort of the precursor to LLMs, which is a form of natural language processing. There's lots of examples of NLP. I'm going to call it NLP now. That's natural language processing in critical care, doing different things, predicting outcomes, extracting problems, treatments, tests. Lots of work on sepsis, and a few studies on AKI there in the middle. And you'll notice a lot of these sort of taper off around 2023. And I think that's the latest one that we found. But basically, the bottom line here is that most of these studies show the same thing, and that's that the text was useful, contained useful information, but only when when it augmented the existing sort of structured EHR, which we call flow sheets and things that are in Epic, basically, sort of dumping from that. Okay, LLMs, these are NLP models. These are language models. So typically what that means historically is meant that it's predicting, so it's modeling language by at any given moment predicting the next word in a sentence. That's all it's doing. Even ChatGPT, it's predicting, like given a series of words that come in, it's predicting what the next one is likely to be. That's all it's doing. But when you pass in billions and billions of examples, it sort of learns how language works. It learns this knowledge by proxy, sort of. These are called emergent abilities, where, and it sounds like scary, the term maybe, but it's after, these researchers noticed that when the models get large enough, suddenly you have this spike in abilities to perform different tasks that they weren't explicitly trained on, like adding numbers, writing code, things like that. Like when the models get big, and I think people are still trying to understand this phenomenon. It's an ongoing topic of research, but the models themselves are just trained to predict the next word in a sentence. Like the sky is blank and it predicts blue. You kind of scale that up and you get ChatGPT, which is pretty crazy. And other emerging abilities here, like knowledge, right? Like one of the big applications so far of LLMs in the research space is this medical question answering task where we'll have a slide on, but yeah, this is kind of an overview of LLMs. And kind of the fun part about LLMs is that now pretty much anyone can interact with AI, right? The art of, so what you type in is a prompt, right? And there's a whole area of research on how to optimize what you're putting into it, and it's called prompt engineering. I think this figure probably from like a year ago or a couple of years ago. I think there's more methods now, but doing AI, whatever that means exactly, can be done by non-coders, people who don't know the math. It's available to anyone. I've seen that the medical students, it's I think it's really cool. They're developing simulators, like patient interaction simulators, by doing some prompt engineering methods and things, making they're making AI-based tools without knowing any code, and you don't really have to. So I think this is really, really one of the interesting, and a lot of these emergent abilities are based on these prompt engineering techniques. This study was, this perspective article was from a couple of years ago. Lots of different use cases for LLMs, for both sides, the provider and the patient. I just have this here because I think some of them you probably are seeing in practice, related to documentation, other administrative tasks. I think some might be coming, and I'll just comment here and say that like a lot of the barriers here to deploying some of the AI work that we're doing is not so much technical, but it's regulatory, it's ethical, it's legal things that I'm not an expert in, but I think no one really knows where to go with it, and things are changing so fast it's difficult to keep up. But lots of implications for some of the technology that we're developing. This slide shows some select studies of LLMs. This slide ends, in mid 2024, but just giving you a taste, if you haven't seen, like, of what LLMs could do. A lot of these are, I think most of these are sort of in research setting, but showing that it like outperforms doctors on different things, and the validity of the study is debatable, because forgot if I have a slide on this or not, but the LLMs, they sort of like vacuum in all the information from the internet, right? And it makes you wonder whether, so this study in the bottom left, for example, sort of outperformed the New England Journal readers on complex case challenges. Well, were those challenges published anywhere online? If the model has seen the data already, it's going to perform well on that data, right? So that's an example of overfitting or data leakage. Another issue of machine learning, but it makes you wonder, with all of these studies, honestly, the superior results. For example, this medical question answering is sort of a canonical task for LLMs in the medical knowledge sort of sphere, that uses a USMLE data set of medical board exam questions, and that's sort of been like the benchmark that everyone has been trying to outperform the previous state of the art. And most recently, we got MedGemini, which is from Google. That was last year. Prior to that, it was OpenAI's GPT-4. But this data set is available online. Like anyone can see it. So it makes you wonder whether the models are seeing that data. Nothing's been sort of like confirmed for sure, because they keep everything very close to the chest these days because of the issues we talked about before. But it does make you wonder, about the validity of the numbers, I guess. We'll say it that way. But this MedGemini is sort of the latest big advancement, I think, in clinical, at surface in clinical LLMs. And they have, it's a very, very huge paper. They have lots of different capabilities they demonstrated, studies with experts. Of course, they showed that their expert rater panel sort of preferred the LLM generated medical summaries or doctor referrals or simplifying medical language for the patients, which are all great tasks. But supposedly the panel preferred the machine generated ones. These are just additional applications. You have maybe EHR search tools, chart review, automated chart reviews, types of tools, or you ask a natural language question about a patient, and it'll sort of sift through all the notes and the EHR systems and return the answer to you. Converting to different file formats and things like that, to clinical trial matching. I mean, the list goes on. Lots of different applications of LLMs in the sort of research, patient care, education, sort of areas there. So one of the big pushes lately, maybe in the past year or so, has been this multimodal LLMs. And I'm not sure if that's the right term anymore, because it's not just language. It sort of is always rooted in language. That's where the LM comes from, language model. But now you're seeing these companies adding in images, other data modalities. In terms of medicine, we have lots of modalities here: vital signs, observations and notes, images, genomics, waveforms. You have wearable sensor data, lots of different types of data. And so in the medical AI domain, a lot of us are working on these multimodal large models that do the same things we mentioned before about learning feature interactions automatically, but this time it's how does this image relate to this vital sign, or and so on, right? So like cross-modal, cross-variable interactions when you start adding these complex data modalities. And so this is an example of visual question answering, which is a form of multimodal, or it's using a multimodal model, Google's MedGemini there. And I don't know if you can see that. I just thought it was kind of interesting. It's, they frame these things with the lowest risk possible. I think they say that, a primary care physician could use this while they're waiting on results from, interpretation from a radiologist to get a better understanding or to communicate results to patient sooner, things like that. But anyway, the model can look at images like this. It can describe, findings, do the impression, simplify the language for the patient, things like that. I mean, lots of different applications, and this is just one of them. And just plugging our own work again on some things in this area. We've proposed a couple of frameworks that we're currently using for various projects that use the underlying technology in a lot of these multimodal foundation models, they're called. So we have this CJSON paper and this Nature Reviews Nephrology paper about this type of multimodal feature interaction, and developing that data-driven context of patient health, whatever that means, at any given time, instantaneous snapshot of patient health, and being able to query that with existing LLMs to sort of better understand different aspects of the patient progression, disease, disentangling all the complexities of real-world healthcare.
Ben,
Yeah.
MedGemini is not available for us, is it?
I don't know. They've been, I haven't looked for it myself because we are developing sort of our own local models that are meant to try to compete. But MedGemini, have you looked into it? It's
Last
Google.
time I looked, they said that it's not available, it's not marketed yet, it's just at the level of the research
Okay.
for you guys, basically.
Okay. So their prior model, we were talking to Google directly because it wasn't publicly available. And we were sort of talking with them about using their models, but we never followed through on that. But I'm assuming similar sort of arrangement. Yeah. That's on my list to see how accessible those are, which aspects are accessible by us. We have a few projects with Jeremy Balch, a surgical resident, also one of my PhD students using LLMs to do various things during surgery. We're looking at also the privacy leaks of LLMs and some of the drawbacks to sort of improve patient safety. His work is all related to surgical quality improvement. And this one also came out a few days ago. This just shows you how fast the field's moving. I mean, there's lots of papers every few weeks. It seems like that are a big deal. This one is about the risk of medical misinformation. So a lot of these LLMs, maybe all of them, are trained on this, at least partially, on this massive data set that's available to anyone that pretty much contains all the internet, let's say, and it also includes PubMed Central, like the full text of every PubMed article, which is like 15% of the whole data set. So lots of information there. This study kind of showed how easy it is to inject misinformation into some of the vulnerable parts of that data set. And by vulnerable, they meant that these are things that are unmoderated. So PubMed is not vulnerable, but when it's scraping sort of online, like public Twitter accounts or X, whatever, Facebook, that's all vulnerable stuff. And they showed that like very small amounts of misinformation being injected into this sea of documents that are used to train the language model can result in much more harmful medical advice. You can't see this, but given to patients if it was being used for sort of patient-facing chatbot, which is one of the proposed applications of these sort of things, without being detected by conventional methods. So like the accuracy and benchmarking, things like that didn't change at all. And so it looks like everything's fine, but in terms of like individual level medical advice, so this says like, do antidepressant work? The result is, of course not, or things like that. So very, very harmful stuff. So this is
Was this like a mock closed database?
yeah. So this
So
is
it's like a closed learning model and then they injected bad information in it?
mhm.
You
but
should
it's-
try it on Google. So a patient brought me and showed what Google AI, just search bar, the answer that it gives. And there are the links to that, and when you click the real links, but it completely misinterprets what the link says. And I did it with several questions of my own that I wanted to validate. It's unable to read it from the journal and actually say journal is pretty clear what the conclusion is.
Yeah.
But what AI interprets it as and puts it up in the paragraph is can be complete 180
Mm.
from what those links they cite are.
It's-
People who don't go one step deeper are unable to interpret. And I have more than one patient come to me and ask, oh, this says that patients with CKD should not take Miralax. Something that simple, and it goes deeper than that. And that's Google, right? Everyone uses Google.
This is like WebMD on steroids for you guys, right? Like patients who think
Sadly.
It gets worse. So, but bottom line, so far, it's not helpful.
Oh, it's bad. It's bad. But the problem is I know it's bad and I still will
It's
like
gonna get
take it
better,
for
right?
myself, like search something, I'll like, even though I know can be bad, I'll still like, all right, fine. If it's not critical, use the summary. I think that's using Gemini, which is maybe why I'm dragging my feet. I'm actually using it for research because I've seen how bad it can be with the Google AI. But yeah, there are lots of issues that it's moving so quickly is the thing. These things are rolling out to everyone and it affects every aspect of society.
Isn't that how it learns? It's learning, right? So isn't that how it learns? Like it needs to go out and get all the data, how many times it's wrong.
Yeah,
Then it will get
that's another, I don't even talk about that, but that's like all this generated data is now that's also going into this pile. That's going to be sucked in by the next version of ChatGPT. It's this sort of like snake eating its own tail sort of thing, it's training on data that it already generated. I'm trying to say like no one really knows what's going to happen there.
Yeah, so the Miralax example, so sorry, I thought it was very telling. So it was a Fresenius link that it's pulled it from because in an end-stage kidney disease patients, they can take Miralax with more water than they should. So it gives everyone who has any kidney disease advice not to take Miralax because it's harmful, which is a laxative, right? Which I thought was very interesting. So it put it to the wrong population and the wrong advice. for something that is benign, right? Even incredibly, yeah, completely benign.
Yeah, medicine is too, human physiology is too complex, right? To drill down, like it's very
It's
context
really
based.
finding the right population, which was, I thought was very interesting, right? And that was probably months ago, so it wasn't years.
I'll go back one slide. Like one of the methods that we're working on is called this retrieval augmented generation. That's where you sort of bring in this external database of real knowledge that you know is true, sort of like, up to date, could be something like that. And you have it sort of pull information from guidelines that you know are legit before it recommends something. So it's a way to reduce the misinformation, hallucinations, and everyone. That's an important technique that we've been using. So way too many slides, I think, to get through because of the good discussions we've been having. But non-LLM work, with time series and the potential for AI to predict disease earlier. Things that some people might say are outdated. I wouldn't. LLMs are all the rage. But I think that part of that could be hype and could be dying down at some point. There is other AI. AI is not just LLMs. A lot of these are working with time series for earlier prediction of AKI, sepsis. A lot of work in the ICU with we're adding multimodal data now, and so we have a couple projects there predicting mortality. We're doing things in the critical context, so the perioperative, or historically in the preoperative, predictions of postoperative complications. Now sort of evolving that into this full continuum from when the patient, even pre-hospital, sort of getting to that when they enter the hospital through when they leave. So following them through surgery and after to triage in ICU or floor, and then until they discharge. And we'll be on time because I whizzed through that last section. A lot of other fun projects that we're doing in the realm of AI for clinical care. So this one is based on an internal grant that we received a couple of years ago now, and we're working with NVIDIA and one of their partners, Mark III, to develop a digital twin of the ICU, and expanding that into whole floor. East Tower, one of the neuro critical care units, I believe. And so at the moment, current stage is sort of building the infrastructure for doing different things. So we're not at the application phase yet, but you can do things like simulating. What I'm most excited about is sort of simulating training, maybe for medical students or physicians, rare cases, rare events. Forgot to say, you put on a headset for this. So this is VR, right? So you can simulate different things. Will it be helpful? I don't know. We'll see. But it's really cool at the moment. You can simulate different things like that. You can, I think a lot of capabilities once this is fully fleshed out. But that's something that's ongoing. Kind of piggybacking off that, we have this another internal grant from UF from the folks at Hypergator Research Computing, and we're going to be building this multimodal foundation model of brain health and neurological trajectory. Sort of like this prior step was making a twin, which is like a digital representation of a physical thing. And the thing here is the ICU in the hospital, so the location, environmental twin. This one is a twin of the patient. And we're kind of like choosing this neuro use case as the first application. Bringing in waveforms from the sick bay. They have an installation in one of the neuro ICUs with ICP and lots of high frequency waveforms that we're going to be using along with medical imaging and other modalities. So pretty excited about that. One of my PhD students and also surgical resident, Jeremy Balch, he's also working on digital twin of tools. So he's looking at identifying surgical instruments on the tray in an effort to potentially reduce waste in the OR. So identifying which tools weren't ever used, and over time, maybe a surgeon never uses certain tools. So you can, stop offering that, or sort of offer it at a second layer or something like that. But this is sort of this. It's pretty cool. It's kind of crazy. He made this digital representation, this 3D model of this instrument, whatever it's called. Looks like scissors to me, but like around 3D with just his smartphone, right? And so anyone can do this at home. So he's loading in these assets, and the goal with this twin though is to generate synthetic data. So taking this and maybe generating thousands or millions of images from different perspectives and angles for the model to learn, to sort of translate that back into the real world to identify real world instruments. Because didn't really cover this, but deep learning especially needs lots and lots of data, which is sort of the bottleneck in a lot of healthcare applications where there's not a lot of data in certain contexts. And so to solve that issue here, we're sort of generating synthetic versions of the real data to see if that improves the performance in the real world. I've worked with Dr. Sarter with his digital pathology. Another one of my students, MD PhD student, received this award, the Oberndorf Award, to look at some of the EHR search and retrieval tools that I talked about, also interfaces for how we can involve you guys in the process of co-developing clinical AI systems. And then sort of to end by plugging this AI Passport program, which is an opportunity to learn more about AI. We're currently developing a curriculum for that. It's through an R25 that we received from NIGMS, this Hyper program. So if any of you guys are interested in learning more, participating in this program, please reach out to me. I'd be happy to provide you with more information.
You already have the clinical AI passport. Actually, you are.
We piloted that
Yeah.
first last year. That was an internal pilot of just one module.
That was the pilot, that one?
That was just the pilot of
I
one module.
suggest everyone in this room, when it is available, go to him and ask for it. It's just like learning PowerPoint these days. We need to know it. And actually, he was doing a great job.
So we did one module there. That was like our own internal team doing that one.
Yeah.
But now we're involving dozens of AI faculty across the university, medical AI faculty, to sort of develop, flesh out the rest of the curriculum and polish it up. And it's a low code, low math way to learn AI. But that's sort of the timeline. So
Perfect. When you generate